So here we are going to talk about the respiratory disorder. The first one, pneumonia. So pneumonia is the inflammation, or pneumonia is the infection of the lungs. So in this picture, we can say this is the trachea, upper respiratory system, then two lungs, and this is the bronchi. So inside this bronchi, in case of pneumonia, the lung alveoli is full of secretion, and also the lumen is narrower because of excess secretion and fluid. And patients have difficulties of respiration, so or shortness of breath. So if you ask me, what are the causes of pneumonia? There are so many causes of pneumonia, like aspiration, bacterial infection, or mycoplasma infection, viral infection, fungi infection, or protozoal infection. So an infection of pulmonary tissues, including interstitial space, include alveoli or alveolus, singular or plural, and also bronchioles. The edema associated with inflammation of the lungs and decrease the lungs compliance and vital capacity, and causes the hypoxemia, means less oxygen in the blood. But most of the times patient came to hospital because of fever. Why fever? Because this is the infection and inflammation of the lungs. Or patient present with the chills, shortness of breath, pleural pain, or productive cough. So pneumonia can be community acquired or hospital acquired. So like a patient got hospitalization because of broken the clavicle or fractured clavicle. But when he got hospitalized because of the other person get infected, this is called hospital acquired, or maybe it is called community acquired. The chest X-ray film show lobar or segmental consolidation, the pulmonary infiltrate, and pleural effusion. So if pneumonia is not treated well, the fluid is accumulated in the pleural space and patient present of pleural effusion. A sputum culture identifies the organism. The white blood cell count and erythrocyte sedimentation rate are elevated. So increase the white blood cell because infection. Also patient present with tachycardia or night sweat and diaphoresis. So in this picture, we can see the sign and symptom, right? So sign and symptom here we see the first one, muscle ache, dry cough, but productive cough with rust color or blood mixed sputum is common at the late stage because of infection. Or patient present abdominal pain, cold in the head and throat, fever, chest pain, nausea, and vomiting. So let me read it one more time. Patient present with fever and chills, elevated temperature, pleuritic pain, trachycardia, rhonchi or wheezing, added sound you found during auscultation of the lungs, or use of accessories muscle during respiration. So it means my patient is struggling for oxygen and our body try to compensate. So accessories muscle participate in inspiration and expiration, mental status change, and sputum productive cough is present. What are the intervention? Keep this note, the pneumonia most common organism are Staphylococcus aureus or Staphylococcus pneumoniae. Also, the patient who have HIV, they have a chance to develop pneumonia. So, if you ask me how we diagnose pneumonia, so pneumonia we can diagnose by chest X-ray and culture. But commonly we use the chest X-ray or arterial blood gas analysis, sputum culture, or complete blood count, also pulse oximetry. So before to talk about the treatment option, I want to tell you the intervention, nursing interaction. We check the oxygen concentration by pulse oximetry and then admin oxygen, monitor the respiratory status, monitor for lower respiration, cyanosis, or cold and clammy skin, encouraging the cough and deep breathing, and also use the spirometer. Also, patient position is important. So, semi-polar position to facilitate the breathing and lung expansion. Change the client position frequently and ambulate as lobulated to mobile secretion. So physiotherapy or movement can help to lose the secretion. So we could provide the chest physiotherapy. It helps. Perform the nasotracheal suction if the client is unable to clear the secretion. Monitor pulse oximetry. Monitor and record the color, consistency, and amount of sputum. Provide the high calories, high protein diet with small, frequent meal. We encouraging our patient intake the fluid up to 3 liters per day because it helps to thin the secretion. Also provide a balance of rest and activities. So my lungs will not get enough oxygen. So if I do more work, I will be tired. So rest is important. Also, we could admin the antibiotics because pneumonia is an infection of the lungs. Admin antipyretics for fever, bronchodilator for shortness of breath, cough suppression because productive cough is common, or mucolytic agents. if dry cough or expectorant as prescribed. Prevent the spread of infection by hand washing and proper disposal of secretion. If we do and maintain the hand wash, we can prevent 95% infection. Like education. So about the importance of rest, proper nutrition, adequate fluid intake to avoid the chilling and exposure to individual with respiratory infection or viruses. Regarding medication and use of inhaler, we have to educate how to use the inhaler. So the particular treatment option, we said, we tell them to take antibiotics as prescribed, chest physiotherapy, antipyretics, oxygen as prescribed, and also increase the fluid uptake. So to notify healthcare provider if fever, dyspnea, hemoptysis, or increase the fatigue occur. So if blood, a cough with blood, which is called hemoptysis. And also it is important to educate your patient to take the pneumococcal vaccine as recommended by primary healthcare provider, refer to the. So if patient is older age or immunocompromised or HIV positive, we advise them to take pneumococcal vaccine. It can prevent the attack of pneumonia. To educate the client that using proper hand washing techniques or disposing of respiratory secretion properly and receiving the vaccine is appropriate will assist in prevent the spread of infection. The next topic is here, it is influenza. So influenza is more common and we know we call it is flu. So also known as the flu and highly contagious active viral infection of respiratory systems. It may be caused by several viruses, usually known as A, B, and C. And yearly vaccination is recommended to prevent the disease, especially for those who are older than 50 years old or who are immunocompromised, those living in institutes or health care provider providing the direct care to the client. The vaccination is contraindicated in individuals who have egg allergies. So here, additional information. So first of all, we have to know if patients are immunocompromised or elderly patient, it is good to advise them to take the vaccine. And next, avoiding those who are developed influenza or frequent and proper hand washing, cleaning, and also disinfecting surface that can become contaminated with secretion. So here a picture, we can see the sign symptom of flu. So patient may present with sore throat or may present with dry cough, excess secretion or rhinitis, high body temperature or fever with chills and headache. Here we are going to talk about avian influenza, shortly called H5N1. So here, affect by birds and does not usually affect the humans. However, the human cause have been reported in some countries. Also, an avian influenza vaccine can be developed for use if a pandemic virus were mass. And reported symptoms are similar to those that are associated with influenza A, B, or C. The prevention measures include thoroughly cooking poultry product, avoid the contact with wild animals, or frequent and proper hand washing, cleaning, and disinfecting surfaces that have become contaminated with secretion. So in this picture, we call another virus is called swine flu. It is H1N1. So it is a type A influenza virus that affects the pig or swine. And it can pass to the human through the contact or air contaminated air. And the human who have swine flu attack, the common symptoms include fever, nausea, and sore throat. So H1N1, this is airborne disease, a strain of flu that consists of genetic materials from swine or avian and human influenza viruses. The signs and symptoms similar to those that patient with the flu. In addition, vomiting, diarrhea, and commonly occur. As I told you, the common signs of flu are fever, sore throat, nausea. Prevention measure and treatment are the same as like flu. Prevention. So we have the vaccine, H1N1 vaccine can prevent it. What are the signs and symptoms? Acute onset of fever and muscle aches, headache, fatigue, weakness, and anorexia. Sore throat, sometimes present with cough and rhinorrhea. So if patient have a flu, what are the intervention? So we encouraging the patient for bed rest or encouraging fluid intake to prevent the pulmonary complication. Also monitor the lung sound by auscultation. And here the provide supportive therapy such as antipyretics for fever or antitussives is indicated. Administer antiviral medication as prescribed for current strain of influenza. Another disease, it is called Legionnaires disease. Legionnaires disease basically is spread through the contaminated water, right? So the risk factor of this is COPD or immunosuppression. So in this picture, you can see Mycobacteria tuberculosis. They can cause tuberculosis. Mycobacteria pneumonia, they can cause pneumonia. Also, Staphylococcus cause pneumonia and Legionella pneumophilia. But Legionella, as I told you, spread through the contaminated food, water, and patient present with cough, fever, chill, body ache, and shortness of breath. So let me read it. Acute bacterial infection caused by Legionella pneumophilia. The source of organism include contaminated air conditioner or cooling towel water, and warms water supply include water vaporizer, water hole, or shower. So spread through the contaminated water. Easy way to remember. Person-to-person contact does not occur, and the risk for infection is increased by presence of other condition. What are the common silent symptoms? Influenza-like symptoms like fever, chill, muscle ache, headache, and that may progress to dry cough, pleurisy, and sometimes diarrhea. So, as I told you, the who are under the risk, the person who have COPD or the person who is immunosuppression. Intervention treatment is supportive and antibiotic may prescribe. What antibiotics we use? We use erythromycin or tetracycline or rifampin, so it can work. Now we are going to talk about the pleural effusion. So in this picture, we can see that lungs, this is okay, but this area, you see the water is accumulate in the angle of the pleural cavity. And when water is pushed the lungs in one direction. So pleural effusion, this is the chest X-ray. We can see the water here. So what is pleural effusion? It is the accumulation of the fluid in the pleural space, you see. And patient complain with pain or inspiration, we call pleurotic chest pain. Or patient can present with dyspnea on exertion or dry, non-productive cough. When patients have a pleural effusion, the mediastinum shift away from the fluid. This area is called mediastinum. So if the fluid is too much, this mediastinum shift opposite direction. So it is left side, right side. So it can push the lung, heart, or mediastinum towards left. So mediastinal shift away from the fluid. So let me read it. Pleural effusion is the collection of fluid in the pleural space. Any condition that interfere with secretion or drainage of fluid in the pleural space will lead to the pleural effusion. Sign symptom, pleurotic pain that is sharp and increased with inspiration. It is the characteristics of pleural pain. Progressive dyspnea will increase the movement of the chest wall on the affected side. Dry, non-productive cough and caused by bronchial irritation and mediastinal shift. Sometimes patient present with tachycardia, elevated temperature, and decrease the breath sound over affected sound. So if you put the stethoscope over there, the breath sound will be decreased. In chest X-ray, the anterior-posterior view of chest radiology film that show pleural effusion. This is showing pleural effusion. So normal lungs full of air, and it will become like, look, black. Because of water, it is come white. And also mediastinum shift to away from the fluid if the effusion is greater than 250 ml fluid. What are the intervention? Identify and treat the underlying cause, monitor the breath sound, place the client polar position. So if you tell your patient for polar position, it helps the lungs to expand, encouraging cough and deep breathing, and prepare the client for thoracentesis, means fluid accumulate through the thoracentesis procedure. And also pleural effusion. Pleural effusion we said here, we said if pleural effusion is recurrent, prepare the client for pleurectomy or pleurodesis is prescribed. So sometimes NCLEX board asks the question about the thoracentesis. Yeah, thoracentesis. So thoracentesis is a technique or procedure to remove the pleural fluid and air from the pleural space. So before thoracentesis start, it is very important take the informed consent and measurement the vital sign, chest X-ray or ultrasound, or place the patient in orthopenic position. The question comes about this orthopenic position. Like a patient have done the thoracentesis. After procedure, the patient management is important, like check the vital sign, monitor the respiratory status, apply the pressure dressing or apply the pressure dressing on puncture site, and check for bleeding, check for crepitus, and also assessment for sign of pneumothorax, air embolism, and respiratory distress. And what are the surgical? If the thoracentesis is not enough, we go for pleurectomy. It is surgical stripping or surgically correction and parietal pleura away from visceral pleura. So in this picture, this is the pleura. Pleura has two layers. One layer attached to the lungs we call visceral pleura, and one layers attached to the along the thoracic case, and that is called parietal pleura. And also another procedure is called pleurodesis. And next disease here, it is called emphyema. So what is emphyema here? So it is the collection of pus within the pleural cavity. The fluid is thick, opaque, and foul smelling. So in this picture, we see the lungs, the fluid is accumulated here. Emphyema with accumulation of pus and pleural space. But it should be normal, supposed to look like this, right? So the most common cause of pulmonary infection and lung abscess caused by the thoracic surgery or chest trauma. So if patient have a history of any thoracic surgery, or if patient have a history of abscess, they can chance to develop emphysema. So the treatment focus on the treatment of infection or emptying the emphysema cavities, or treating the infection, or re-expanding the lungs and controlling the infection. So what next? So what are the signs and symptoms of the emphysema? Keep it note, the few diseases are most common. I mean, not most common. Few disease sign symptom is most close, like COPD, emphysema, or chronic bronchitis. These three, the sign symptom is almost same. And here, recent febrile illness or trauma. Patient give a history of recent trauma, chest pain, cough, dyspnea, anorexia, and weight loss. Sometimes malaise, elevated body temperature, night sweat, or pleural exudate on chest X-ray. So you see, this is the pus collected from the lungs because of emphysema. So what are the intervention? Monitor the breath sound, place the client semi-polar or high polar position, encouraging cough and deep breath, admin antibiotics, instruct the client to splint the chest as necessary. Also, assist with thoracentesis or chest tube insertion to promote the drain and lung expansion. If marked pleural thickening occur, prepare the client for decortication if prescribed. And this is a surgical procedure that involves removal of restrictive mass of fibrin and inflammatory cell. So I said the nursing intervention is super important here. So first of all, we go for assessment the respiratory status, right? We educate our patient for pursued deep breathing or deep breathing exercise, or tell your patient not to smoking, or smoking cessation is important. Also, avoid exposure to the cold. Influenza vaccine is important. Also, humidified air. Increase the rest period. Also, suctioning is necessary. Now go for pleurisy. So pleurisy, it is an inflammation of the visceral and parietal membrane and may be caused by pulmonary infection or pulmonary pneumonia because of infection. The visceral or parietal membrane rub together during the respiration and causes the pain. Pleurisy usually occurs as one side of the chest, usually in the lower lateral portion in the chest wall. So, what are the signs and symptoms of pleurisy? Like patient complain of pain that is aggravated on deep breath or coughing, shortness of breath, or pleural friction rub we can hurt during auscultation. So what are the nursing intervention? We identify and treat the cause, monitor the lung sound, or administer analgesics as prescribed. Apply hot and cold application as prescribed, encouraging coughing and deep breath, and the client is instructed to lie on affected side to splint the chest. Now let me talk about the pulmonary embolism. So pulmonary embolism, due to some unknown reason, the NCLEX board like to ask the question from pulmonary embolism. So pulmonary embolism, it is occur when thrombus forms, most commonly the deep vein. So if thrombus formation in the calf muscle or deep venous, it travel and it leads. So maybe thrombus formation in the lower extremity. Then when they passing through microcirculation like lungs, they fall in stuck. So this is the embolus in the lower extremity. Then they're traveling to the iliac vein, then go to the inferior vena cava, enter to the heart. Through the heart, they go inside the lungs and fall in stuck because the lungs has a lot of microcirculation. So you see, they fall in stuck in bifurcation and blockage the circulation. So pulmonary embolism occur because of thrombus or embolus. So what are the difference between thrombus and embolus? Like this one, I call thrombus, but this one I want to call, sorry, this one is called embolism, but this one I want to tell thrombus. Why? Embolism or embolus is a mobile. They can travel, right, through the circulation. But this is the thrombus because thrombus is a stationary. It does not move. And pulmonary embolism is a life-threatening condition. Sometimes it is a result of thrombophlebitis or deep vein thrombosis. Let me read it. Pulmonary embolism occurs when a thrombus forms, most common in the deep vein. When this embolus travels to the right side of the heart and then lodged in the branch of pulmonary artery. The client prone to pulmonary embolism are those at the risk for deep vein thrombosis, include those with prolonged immobilization after surgical operation, obesity, pregnancy, heart failure, advanced age, also history of thromboembolism. So this is the risk factors. They have a chance to develop pulmonary embolism. So if anybody is prolonged bed rest, like after surgical operation, advanced age, heart failure. So long, example, you are traveling from New York to London. So long plane rider, because of immobilization, have a chance to deep vein thrombosis or pulmonary embolism. Or pregnancy, obesity, and congestive heart failure are most common. Also, fat emboli can occur as a complication after the fracture of long bones and can cause pulmonary embolism. The treatment is aimed at prevention through the risk factor or recognition and elimination. So how we diagnose pulmonary embolism? So if there is a suspicion for pulmonary embolism, a D-dimer blood test may be prescribed. But first diagnosis is a chest X-ray or VQ scan, complete blood count we do, or CBC. Complete blood count, we can say thrombocytosis, or according to this, D-dimer blood test. So blood test for D-dimer, if it is negative, it rules out the diagnosis. So which measure one of the breakdown product of blood clot? If normal, the likelihood of a pulmonary embolism is very low. D-dimer below 250 nanogram per ml. So if D-dimer is more than this, it indicates a pulmonary embolism. Also, we should check the prothrombin time or partial thromboplastin time is safe for the patient to check EKG, electrocardiogram of the heart, or blood gas analysis. Also, we go for assessment of Homen sign test. So Homen sign test, it is the test we check for deep vein thrombosis. So D-dimer is not diagnostic, they said. But if the D-dimer is not normal, computed tomography of pulmonary angiogram is ordered, right? It can help. So what are the common sign and symptom of pulmonary embolism? Like apprehension, restlessness, blood, strange sputum, chest pain, cough. During the auscultation, we found added lung sound like wheezing, but wheezing is most common in asthma, crackles, cyanosis, distended neck vein, shortness of breath, or dyspnea, accompanied by anginal or thoracic pain, feeling of impending doom, hypotension, petechia over the chest, and anxiety means bleeding inside, shallow respiration or trachypnea and tachycardia. What next? Nursing action. So nursing intervention is very important. The first priority is bed rest, give oxygen, patient position like Fowler position, and we give them heparin or coumadin. It is the anticoagulant. Also, thrombolytic drugs. Thrombolytic drugs breaks the clot. Let me read it. It is important to notify the rapid response team and healthcare provider. Reassure the client and elevate the head of the bed. Prepare to administer oxygen. Obtain the vital signs and check the lung sound. Prepare to obtain and arterial blood gas. Prepare for administration of heparin therapy and document the events, intervention taken, and client response to the treatment. So heparin can work for thrombolytic medication. Now, let me talk about histoplasmosis. What is histoplasmosis? Histoplasmosis, it is the pulmonary fungal infection caused by the spore of Histoplasma capsulatum. So transmission occurs by inhale of spore, which are commonly found in contaminated soil. The spore are also usually found in bird droppings. So if patient have a histoplasmosis, what are the signs and symptoms? Sometimes patient present with side symptoms like pneumonia or positive skin test for histoplasma or positive agranulation test, splenomegaly, hepatomegaly. So liver enlarged or spleen going to get bigger. And histoplasmosis is an infection, right? And an infection causes by breathing in the spore of fungi, and often found, this fungi often found in the bird, right? The infection is most common spread when these spores are inhaled after taking to the air. But histoplasma can attack our lungs and can attack our kidney as well. So what are the intervention? Admin oxygen as prescribed, monitor the breath sound, assist to administer antiemetics, antihistamine, antipyretics, and corticosteroid as prescribed. Also, it is important to assist to admin fungicidal medication, means the medication that kill the fungi or that inhibit the growth of fungi. So can works. Encouraging cough and deep breathing, monitor the vital sign, and also here as appropriate, the client is educated about the importance of spraying the floor area with water before swimming the pond and chicken pool. So sarcoidosis, another disease, means it is the presence of epithelioid cell tubercle in the lungs. The cause is unknown, but it is a high titer of Epstein-Barr virus. So particulate sarcoidosis is occur because of infection. And because of infection, when infection attack the lungs, this is called antigen or pathogen, and our body can produce antibody. This antigen antibody complex formation, and they get bigger. We call it epithelioid cell tubercle. Because in sarcoidosis, the growth of tiny collection of inflammatory cell in the different parts of the lungs. And sarcoidosis or the growth most common occur inside the lungs or lymph node. Sometimes it is occur in eyes or in the skin. So they said highly titer of Epstein-Barr virus can cause. And also viral incidence is higher in African American or young adult. So if anybody has sarcoidosis, what are the presentation or sign symptom? Night sweat, fever, weight loss, cough, skin nodules, polyarthritis, right? And here you see sarcoidosis can attack our eye, skin, heart, spleen, and causes splenomegaly, even joints, causes arthritis. So they can make granulomas or scar inside the lungs. If liver get involved, hepatomegaly, liver get enlarged. Skin, erythema nodosum. So what are the intervention? Admin corticosteroid to control the symptom, monitor temperature, increase the fluid intake, provide frequent period of rest, encouraging small and nutritious food. Now let me talk about another disease called tuberculosis. So tuberculosis, it is the organism, the highly communicable disease. And tuberculosis is a airborne disease caused by Mycobacterium tuberculosis, the organism name. So Mycobacterium tuberculosis is a non-motile, non-sporulating acid-fast rod that secrete the niacin. When the bacilli reach a susceptible site, it implies the freely. So the mycobacteria is spread by droplet nuclei, and they lodged high in lungs, right? So because the Mycobacterium tuberculosis is anaerobic bacterium, it affects primarily the pulmonary side, means lungs, especially the upper lobe, where the oxygen content is highest, but it also can affect other area of the body, such as brain, intestine, peritoneum, kidney, joints, and liver. So most of the times, mycobacteria attack the lungs, and we call pulmonary tuberculosis. But it is also common, mycobacteria can attack the kidney, can attack the brain, can attack the intestine. So what are the risk conditions? Mycobacteria attack usually malnutrition person or highly crowded living condition, or socioeconomical status, alcoholism, IV drug abuser, or immune dysfunction. They are under the risk. So tuberculosis has an insidious onset. It's a bacteria, and many clients are not aware of the symptom until the disease is well advanced. Improper or non-compliance use of treatment program may cause the development of mutations in the tubercle bacilli and resulting in a multi-drug resistant strain of tuberculosis, shortly called MDR-TB, multi-drug resistant TB. The goal of the treatment is to prevent the transmission, control the symptom, and prevent the progress of disease. So let me talk about transmission, disease progress, client history, clinical manifestation, and diagnosis, and also the client or nursing education. Tuberculosis is the most common and frequently occurring area in NCLEX board. First of all, transmission. So transmit via airborne. So it is the airborne precursor or the route by droplet infection. When an infected individual cough or when the person is laughs or sneeze or droplet nuclear contaminating tuberculosis bacteria enter the air and may be inhaled by others. Identification of those in close contact with the infected individual is important so that they can be tested and treated as necessary. When contact have been identified, this person are assessed with a tuberculin skin test or chest X-ray to determine the infection with tuberculosis. First of all, we go for sputum test. Sputum for AFB means acid fast bacilli. Then chest X-ray or PPD TB test we call. So next here, disease progression. Droplet enter the lungs and the bacteria from the tuberculation, the defense systems of the body of tuberculosis leaving a scar. So when bacteria enter the lungs and body try to defend, antigen antibody reaction occur and scar tissue develop. It is a complex we call gon focus. If the encapsulation does not occur, the bacteria may enter the lymph system or travel the lymph node and causes the inflammatory response, and it is called granulomatous inflammation. So granuloma formation. The primary lesion form. The primary lesion may become dormant, but can be reactivated and become a secondary infection when re-exposed to the bacteria. So if anybody have a TB, the scar have to be continued lifelong inside the lungs, but it is inactive. So is in an active phase, tuberculosis can cause necrosis and cavitation in the lesion leading to rupture and spread of necrotic tissue and damage to various parts of the body. So what is the client history? So patient usually give the past exposure of TB or tuberculosis. The client's country of origin, travel to the foreign countries in which the incidence of TB is so high. Usually the developing country, overcrowded living people have suffered more, and developing country, most of them have a poor socio-economical status. Malnutrition are common, so TB is more common. But in developed country like Europe or America, TB common because of HIV, because of immunosuppression. The recent history of influenza, pneumonia, febrile illness, cough, foul-smelling sputum product. The previous positive test of tuberculosis result of testing. So recent bacillus or a vaccine contaminated attenuated tubercle bacilli that may be given to the person in the foreign countries or the person traveling to foreign countries to produce increase the resistance to tuberculosis. An individual who has received the vaccine is called BCG vaccine will have a positive tuberculosis skin test result and should be evaluated for tuberculosis with a chest X-ray. So, clinical manifestation. The presentation or side symptoms of TB, sometimes it is asymptomatic, means patient has TB but no sign and symptom. If the symptomatic TB patient present with fatigue, lethargy, anorexia, weight loss, low-grade fever, chill, night sweat, or persistent cough, and also production of mucus and mucopurulent sputum, which is occasionally streaked with blood, chest tightness, and a dull, aching chest pain that may accompany the cough. So sometimes patient present with low-grade temperature fever, pleuritic chest pain, night sweat is more common, or chronic productive cough. So if anybody have a cough more than 3 weeks with fever and usually body temperature raised at the evening or night sweating, it's suspected for TB. Sometimes patient with anorexia, fatigue, malaise, pallor, and weight loss. There are 3 cardinal signs of TB. One is weight loss, low-grade fever, night sweat. And what next? So here, the diagnosis, the chest data collection and diagnosis here. So a physical examination of the chest does not provide conclusive evidence of TB. The chest X-ray flame is not definitive, but the presence of multi-nodule infiltration with calcification in the upper lobe suggests the tuberculosis. If the disease is active, or caesation or inflammation may be seen in the chest X-ray. But as I told you, first of all, we check the sputum for AAB, acid fast bacilli. For 3 negative AFB specimen to discontinue isolation, important for NCLEX board. And PPT, it is the PPT means TB test. And also we do for bronchoscopy and chest X-ray like this. In advanced disease, dullness with percussion over the involved parenchymal area, and also bronchial breath sound, bronchi, crackles indicate advanced disease, or partial obstruction of a bronchus caused by endobronchial disease. So now about the tuberculosis skin test, right? So a positive reaction does not mean that active disease is present, but indicate previous exposure of tuberculosis or presence of inactive disease. So this is the PPD test or tuberculosis skin test we do, and we check the measurement. Once the test result is positive, it will be positive in any future test. And skin test interpretation depends on two factors: measurement in millimeter of the in duration and person rates of being infected with TB, and progression to disease if indicated. Once an individual's skin test is positive, it will be positive in any future test. Chest X-ray is necessary to rule out active TB or detect the old healed scar. Now, hospitalized client. The client with active tuberculosis is placed under airborne isolation. So airborne isolation precursor with a negative pressure room, and to maintain negative pressure, and door of the room must be tightly closed because it is an airborne. The room should have at least 6 exchange of fresh air per hour and should be ventilated to outside environment if possible. The nurse must wear a particular filter respirator, or when the care for the client with a ground when possibility of exists to contamination of clothing. So hand washing is required before and after caring the client. If the client needs to leave the room for the test or any procedure, the client is required to wear a surgical mask. Respiratory isolation is discontinued when the client is no longer considered infection. As I told you, sputum for AFB, three negative AFB specimen discontinue for isolation. After the infected individual have received the tuberculosis medication for 3 to 3 weeks, the risk of transmission reduces gently. So, what are the medication we provide? We provide isoniazid. We also, if patient prescribed isoniazid, patient chance to develop peripheral neuritis, it is the hepatotoxicity, GI upset. So vitamin B6 or pyridoxine should prescribe with isoniazid to prevent peripheral neuropathy. Also, we give rifampicin. Rifampicin causes discolor of urine, contact lens, or orange color of the body fluid. Sometimes we prescribe the streptomycin, or drugs may be given in combination to decrease the risk of resistance. So, what are the client education and what are the nursing intervention? Let me read it. So, provide the client and family with information about tuberculosis, about the contagious aspect of infection, Instruct the client to follow medication regimen as prescribed. Advise the client to cite an adverse effect of medication and also ways of minimize them to ensure the compliance. As I told you, isoniazid is a medication that can cause peripheral neuropathy. How you prevent peripheral neuropathy? If you give them vitamin B6 or pyridoxine, it can prevent peripheral neuropathy. Advise the client to resume activities gradually. Instruct the client about the need for adequate nutrition, well-balanced diet, and promote healing and prevent recurrence of infection. Inform the client and family that respiratory isolation is not necessary because the family members already have been exposed. Instruct the client to cover the mouth and nose when coughing and sneezing, and use the tissue into the plastic bag. And instruct the client and family about hand washing, and inform the client that when result of 3 sputum culture are negative, the client is no longer considered infectious and usually can return to formal employment. Advise the client to avoid excessive exposure to silicone or dust because this substance can cause further lungs damage. Instruct the client regarding importance of compliance with treatment, follow-up care, and sputum culture as prescribed. So, nursing intervention is important. As I told you, respiratory isolation is very important, at least 2 to 3 weeks after starting medication. And this tuberculosis is an airborne disease. So airborne precursor and N95 marks is important. Or educate your patient and teach to cover the mouth and nose when cough and sneezing, and dispose the contamination tissue into the plastic bag or paper bag. Good hand wash is important. Marks the patient for transport and increase the fluid and promote the proper nutrition and also oxygen as prescribed.